So moving on to our final and certainly last but not least presentation for the day. This is immune effector cell therapy and neurotoxicity and the impact of psychological support by Meredith Beaton and Maria Olex. So Meredith Beaton is a nurse practitioner in the Division of Hematology and assistant professor in the School of Medicine and serves as an adjunct professor at the CU School of Nursing. She is also the Department of Medicine's Associate Vice Chair for APP Development and Mentorship and the Bone Marrow Transplant Inpatient Medical Director. After completing her BA at Wellesley College and her master's at Columbia University, Meredith worked for several years as a middle school teacher. She then switched her focus to nursing and obtained her BSN and acute care nurse practitioner degree from the Yale School of Nursing. After completing her acute care nurse practitioner, she joined the hematology division at CU, where she focuses on myeloid malignancies and cellular therapies and about 10,000 other things in our division and beyond. Maria Olex is a assistant professor and licensed clinical psychologist in the Division of Hematology at the University of Colorado. Maria received her doctorate of clinical psychology from Adler University in Chicago, where she specialized in behavioral medicine. She completed her internship at Medical College of Wisconsin and her postdoctoral fellowship at Henry Ford Medical Center in Detroit. Prior to joining the University of Colorado, she was an assistant professor and inpatient palliative care psychologist at Medical College of Wisconsin and has worked in cancer psychology for 6 years. Her research interests include caregiver support, sexual health and hematologic malignancies, and adjustment to illness. Please welcome Maria and Meredith.
Hello. Oh, no. Hello. There we go. Okay. So first of all, thank you to all of you for sticking it out for the last talk of the day. It's always a tough spot to be in as a presenter, but we are going to make it worth your while. I promise. So these are our learning objectives. We're going to talk about IEC therapies, neurotoxicities. We would be a terrible talk if we didn't also touch upon cytokine release syndrome. So we will do that as well. And then we're going to talk, I think most importantly today, about like, how do we integrate the care of these patients as they are experiencing these side effects. So I'm really excited to be able to present with Maria because I feel like this is something that, you know, when you get hyper-focused in on the medical side, right, it can be really easy to forget that it is a whole human sitting in front of you, also probably with a whole support team. And so it's really important that we all understand both sides and how we care for folks. Okay, we have no disclosures. Okay, so let's take it back a notch, right? We love to throw around immune effector cell therapy, IEC therapy, right? We have all these acronyms that we use because all the names are really long for things, and that's lovely. But what does that mean, right? Well, it means we use the patient's own body and their own immune system to fight off their disease. And that is really cool because a lot of what we have worked with in oncology for so many years has been giving them very highly toxic chemotherapy. And that is very not cool, right? And so this is great. So the toxicity profiles are much better tolerated and different than what we saw from traditional chemotherapies. So we have a few different types that we can talk about. We are not going to talk about all these today, don't worry. Chimeric antigen receptor T cells, or CAR T. Again, we have a lot of acronyms. Names are long, so I wanted to give them all out there for you. Tumor infiltrating lymphocytes also falls into this category, or TIL products. We're not talking about those today. Bispecific T cell engagers, or BiTEs. You heard some of my colleagues talk about that earlier. T cell receptors, or TCRs, or sometimes these are also called TCR T cells. There's a whole bunch of different names for that one. When we think about these products, again, I just wanted to make sure we're all starting on the same footing here. Okay, so a BiTE is a very nice off-the-shelf product, so it doesn't require manufacturing from a patient's own cells. And essentially, it just goes out as a little link. Sorry, I'm an ARM person. As a linker, and it says, "Hello, T cell. Hello, cancer cell," and it connects them and then activates the T cell. And that T cell says, oh my gosh, I know what to do. And it fights off the cancer. And it's great. So great. So we like that one a lot. We have several FDA approved bites in the heme world. Just one right now in solid tumor. However, this is changing like, oh my gosh, tomorrow there will probably be a new bite that is approved and another new one and another new one. It changes so quickly. A CAR T, right? So this is our chimeric antigen receptor. We take the T cells from a patient. Great. We stick an arm on them that identifies their cancer cell. We put them back into the patient's body. And again, that T cell is carried to the cancer cell and it connects and it says, oh, now I know what to do. And again, fights off the cancer. Amazing, right? Okay, these are our FDA approved CAR Ts. We have them for CD19 or BCMA. Again, this is changing all the time. They are coming and they are also coming for solid tumors, which is really exciting, as well as for some of our non-oncology patients, which is very cool. Okay, we have our TCRs, right? Again, this is where we just have an enhanced sort of T cell, and it has an arm that says, oh, hello, I know how to identify a cell on the surface of this cancer. Great, I will do that. Attach, activate, right? You're noticing a theme here? There's a lot of activation happening. Okay, this is our one TCR that is currently approved. However, again, so many in the pipeline. Okay. And last but not least, our tumor infiltrating lymphocytes. These are a little bit different. We have a solid tumor patient, most likely a melanoma patient right now, although again, still in development for other types of cancers. We take out some of their tumor. We then pull out the T cells that are already in there that clearly know what they're doing. And we just reproduce a lot of those in the lab. And then we take those T cells and put them back into the patient. And since they knew what they were doing before, they still know what they're doing now, and all their clones do, and they go find the cancer, attach, activate, right? So very exciting. This is an exciting time, I think, to be in the world of oncology with all these therapies. This is our one FDA-approved TIL. More are coming. Okay, lots of clinical trials using all these therapies. It's all the rage. I just pulled up our own data from CAR T because I think it's kind of cool what we have done, at least here. I'm biased, I know. But back in 2017, you can see we did, I don't know what that number is, maybe 3, right? CAR T products. And now in 2024, we did over 80, right? Like this is booming how much we are able to provide this for patients. It's really cool. So let's talk about CARs. Why are we going to talk about CAR T? We focused on this today because when I think about the side effect profile of some of these things, especially for bites and TCRs, they can get these toxicities, but usually they are much lower grade, they resolve much more quickly, and they don't tend to have prolonged effects. When I think about who's going to be the worst offender in this category, I think about the CAR T product. And that's okay. You know, it's still a really good product. We just need to know how to work with the CAR T, not against it, you know? So this is my friend, the CAR T. These are the side effects that we think about. Short-term side effects versus long-term side effects. Short-term side effects are classic that we always think about. Cytokine release syndrome, which we'll talk about. Neurotoxicity, which we'll talk about. Cytopenias, right? Usually a lot of it's from the LD chemo that we have to give in order to make a nice, happy home for the CAR Ts. Infections, always. And then we have some longer-term side effects. We're not going to talk about these today, but we are going to talk about some other longer-term side effects. Okay, so just to recap, cytokine release, this is our friend. We are all very familiar with this post-COVID. It is the trifecta of symptoms. At least that's how I think about it, right? You got to have a fever, plus minus hypotension, plus minus hypoxia, then you have CRS, right? We have a whole grading system that the ASTCT has told us. We have standardized guidelines for how we grade this, right? Based on mostly how bad is your blood pressure / what does it need in order to stabilize? Does it need just a bolus or does it need pressors, right? How bad is your hypoxia? Is it like you need 2 liters nasal cannula or do you need intubation? Okay. Those are kind of the degrees at which we're going for here. And then, once we grade it, then we can treat it. And I will just call out that the way that we treat cytokine release syndrome, we love to give steroids. We didn't always love to give steroids. If any of you were around about, 7 or 8 years ago when we first started off, we were very cautious about steroids because we thought it might affect the CAR. We have all since come to realize that, in fact, steroids help us save people's lives, and that's great. We also give another medication called tocilizumab or TOSI. right? It's an IL-1 inhibitor. All that does is pump the brakes on the immune system. Remember how I said, okay, I got all these cells running around and they activate once they find the cancer cell? They're not smart enough yet to deactivate. And so we get them really excited and then they go a little bit bonkers, you know? It's maybe, if I were to draw an analogy, like, you know, teenagers whose parents are away for the weekend and they invite just a few friends over. And then, you know, it gets a little wild and crazy, okay? That's what happens sometimes. And the immune system can't turn it off. So we have to like pump the brakes a little bit, right? Okay. This is what we are going to talk about today and focus on the most, as well as some of our other neurotox longer term effects. Not your grandma's altered mental status. That's how I think about this. This is not altered mental status where you walk in and you say, Mr. Smith, what year is it? And he says, it's 1924. And you say, okay, where are we right now? We are in Bermuda. You know, like it's not like that. This is your brain on cytokines, which is a weird place for your brain to be, and it doesn't like it very much. So the same capillary permeability that causes all the side effects of CRS also cause capillary permeability in the brain. We think that this is what's happening. And those cytokines that are running around causing CRS then cross through those little holes in the capillaries into the brain. And the brain says, I don't like that at all. And so patients develop what we call ICANS. We ask them this lovely, what I refer to as the pop quiz, the 10 questions every day. Now, here's how it often starts off for me. Patients memorize these answers, and then they say, this is the most useless quiz ever because I am never going to get these wrong. I have these memorized. I know my answers. And I say, yes, I know, Mr. Smith. And then, 12 hours later, they develop a fever. And then the nurse goes in to assess their ICE score and get all the rest of their vital signs. And you ask Mr. Smith the same questions. And you say, hello, Mr. Smith, what do you call this thing? He says, a book. And you say, great. What's this called? A book. What's this called? A book. And that's how it goes. And it will get worse from there, sometimes for some patients, right? But it becomes this kind of usually repetition of the same word over and over. And it can be very alarming. We will talk about some situations in which this becomes the most alarming. Counting backwards from 100 by tens, the patient will fool you. They'll get all the way to 20, and then they'll go 20, 20, 20, 20. And you say, whoa, we were doing great. We had all the other answers, right? So it's really important we ask all 10 questions every single time because you never know when the tipping point will be. Okay. Once we grade it, then we can manage it. It's really important that we not be afraid to give steroids in this situation because that lovely IL-2 inhibitor, right, tocilizumab that we give like candy for our CRS patients does not cross the blood-brain barrier. So it can't help out the poor little brain up there. Steroids, though, they do. So we give a lot of those. We also can give anakinra for slightly refractory ICANS or for higher grades. Anakinra is an IL-1 inhibitor, and that will cross the blood-brain barrier. Okay. So we're going to talk about the first patient. Mr. L, he is a 56-year-old Spanish-speaking male who has relapsed refractory B-ALL. He is admitted for his Tecartus CAR T therapy. He's currently day +7. In the morning, he was seen by the team using his interpreter. His ICE was 10 out of 10. However, the provider is called to the bedside approximately 3 hours later by the RN for a change in ICE score. At this time, the patient is only able to repeat his name in response to each ICE question. His ICE is now 1 out of 10, and he has a grade 3 ICANS. I will also tell you that this patient is based on a patient that I took care of, and it was really terrifying to the poor interpreter who was trying to ask these questions and assess this patient with me. So it is really important that you prepare all members of your team for these side effects as you are starting to care for them.
All right. And now while the team is managing ICANS medically, we also need to remember the psychological impact on both the patient and their family. So this sudden change can be terrifying. When patients develop neurotoxicity, they are not only neurologically vulnerable, but also psychologically fragile. The distress they experience can be profound: confusion, fear, loss of speech or mobility, often without understanding what's happening. We manage this distress in 3 phases. First, we really need to prepare them in advance. So explaining that temporary brain effects may occur, setting expectations really helps reduce shock when symptoms appear. And this is in the pre-treatment phase. So this is when psychology meets with the patient and their family member and or even the medical team, because it really needs to be echoed across. We need to educate them on what to expect. Now, oftentimes when we educate people and their, family members, they're in a time of just a lot of feeling overwhelmed, right? So it kind of goes in one ear, out the other. And so we need to constantly remind them. When neurotox resolves, they really don't remember. That's why we need to touch on caregiver support sometimes. And sometimes this is so severe that they end up in the neuro ICU. And so it's even preparing their family members for what's to come, right? So at worst, this might happen. At best, this might happen, and walking them through every step of the way. Yeah. All right. Now, during the acute phase, we provide calm, consistent reorientation. We reduce environmental triggers and use soothing language. So things like, you're in the hospital, you're safe, we're helping you get better. If they're confused or agitated, we want to validate rather than correct. Oftentimes familiar voices. So family members being in the room and present can be really helpful, but also we as the medical team and their providers, they know us, right? And so being consistent there and just, again, reassuring them that they're okay. Oftentimes music helps folks, or gentle touch can be really grounding as well. And so I think kind of with all the treatment in this acute phase, it's really like you're treating somebody with delirium. And I'll tell you the difference between delirium and what we're talking about here, this neurotox, because it's different. But the treatment, when we talk about just the psychological support that we're providing the patient in that moment, is very similar. We're also using that emotional support. So again, using calming, non-threatening language, avoid complex explanations, acknowledge their fear or confusion. So saying something like, you may be feeling scared or disoriented. That's not unusual. We're here and you're safe. Validate their experience without trying to correct illusions or agitation if they're present. And again, present touch can be really helpful, but that's as tolerated. So somebody that has a trauma history, for example, using touch can be really harmful. And so you really want to know your patient. But again, eye contact, low and slow tone of voice to reduce arousal is really helpful. So the psychological interventions in the moment, there's these crisis intervention techniques where this may or may not be helpful. Again, when a patient, for example, is completely out of it, repeating themselves, repeating the questions that we're asking, as Meredith was just saying, some of these strategies might not work. So we really have to meet patients where they're at. But I often use grounding strategies. So things incorporating our sight, our touch, our breath, asking a patient, name 5 things in a room. If you have a blanket by you, pull up the blanket to them and ask them to really feel the blanket. What does it feel like? So incorporating that sense of touch. Again, using repetition, you're in the hospital, you're getting treatment, you're not alone, reassuring the patient. That's essentially the number 1 intervention that I would say is really important. For those that are anxious or panicking, teach paced breathing. Again, breathing may or may not be helpful. So I really want to reiterate that. When somebody is completely panicked, telling them to breathe is not going to work, right? So you really have to know where they're at. But the paced breathing, you can say count to 4, hold it for 4, release for 4. I really like to use my hand because this also incorporates that sense of sight and touch. So every time you trace up, you breathe in. When you go down, you breathe out. And again, if the patient is with it enough, they're able to do that. But if they're not, don't do that. It's going to confuse them even more. And then distraction yet again. So using calming music, having white noise, some guided visualizations can really be helpful. There's a ton of different apps that we can use too. So Insight Timer is a good one. Calm is another good one. Again, know the patient though, and know where they're at before incorporating any of this. For patients who can't speak or are delirious, we comfort through environmental cues and presence. And so distress can really manifest as moaning, pulling at lines, restlessness. And then we use the environment, like I just shared, to really reduce lights or noises that might be agitating the patient, orienting them with a clock or a calendar in front of them. Familiar smells can also be really helpful for patients. And I think the most important thing here is to avoid unnecessary restraints. Obviously, sometimes we need to restrain patients, but avoid unnecessary restraints. This really worsens distress and trauma. All right, we are going to have many complex patients too, that have developmental delays, that have language barriers or psychosocial issues. Meredith touched on this just a bit, but really here we want to meet patients where they're at. So using language that's appropriate, using their developmental status rather than their chronological age is really important here. And with the language barriers, using an interpreter. Oftentimes, family members want to act as the interpreters. That's all fine and dandy. Although in these cases, it's really not, because we don't know what the family members are really saying to the patient. You know, I've had some family members, I know just a little bit of Spanish, enough to get me by. And sometimes when I've had family members act as the interpreter, I could sense that something is a little off, right? Like they're missing some of the things that I'm trying to say. And so we really want to use a professional in this setting. All right. So here we want to meet patients at their baseline. So consider modifying the ICE testing, use pictures instead of questions. Don't judge handwriting when a patient is rigoring. It's important. And then I just touched on the interpreter expectation management. And then managing hospital delirium versus ICANS. This is important. There's differences between the two. Really, I think the biggest takeaway here is that the treatment is going to be different. So for folks that have ICANS, they're going to respond to steroids. For folks that have delirium, they're not going to respond to steroids. And so that is, you know, the treatment to this is really important. Now, folks can certainly also be delirious in conjunction with ICANS. And so we use our delirium precautions, ones that you would use on any patient that's delirious in the hospital. But you also want to treat ICANS. And so you want to treat the underlying issues that's causing either the delirium or the ICANS. And this goes back to knowing your patient. Oftentimes family members know patients a lot more than we do. And so relying on family as well, although in a few slides here, we'll talk about the difference, or sorry, we'll talk about sort of how to support the caregiver in this too. And so oftentimes they might be stepping out. They're not always at bedside. So it's really important to get to know the patient before they come in, but when they come in to spend some time talking to them before they start their treatment, as you know, they're going to progressively get worse.
All right.
Oh, no, you take it away.
Okay. So we're going to talk about another patient case. This is Mr. R. He's a 52-year-old male with multiply relapsed B-ALL with CNS involvement. He is coming in for Tecartus CAR T, known to have ICANS, with his prior BITE therapy, which was Blina. Prior to starting therapy, his wife informs you and the team that she will not be present for his therapy due to prior neurotoxicity, but will be available for updates and decision making. And I will tell you that when I first heard this from this patient's wife, I said, oh, okay. I said, could you just give me some more insight into that just so that we know how to support you best? And she said that he had previously wound up in a neuro ICU with his ICANS from his blinatumomab, and she was actually still seeing a therapist for her PTSD from that experience. So I just use this example in particular because it can be so impactful on the patient caregivers. And I think we do such a great job of focusing on patients, and that is so, so, so important, obviously, to everything that we're doing. But thinking about their caregivers and the trauma that they have also gone through and witnessing some of these things is so important. And I think it's really important that we present a united front as we're doing that as well. In the morning, he is seen by the team and his ICE score is also 10 out of 10. And the provider is called to the bedside approximately 20 minutes later. Let's call that out for a quick second, because patients can be fine and then turn on a dime. And that makes it also very challenging. He also has a change in his I score. At this time, he cannot answer his name, the hospital, and when asked the year, he states it's 1927. And then every answer after that was 1927. His ICE is now a 2 out of 10, and he is a grade 3 ICANS. Oh, oh, there we go. So what do we do now?
All right. So realistically, many patients don't remember the acute phase, but feel a lingering sense of fear or unease. We really want to validate this and provide psychoeducation. Your brain was inflamed, and that can make memories feel foggy or scary. What you're feeling is real. After recovery, we don't assume that they're fine. We screen for trauma and adjustment issues and offer therapeutic services. So many carry this emotional weight from this experience, even if their memory is foggy. In short, managing distress during neurotox requires clear communication and really trauma-informed presence and integrated psychosocial care. Okay, so the slides that I had worked on did not upload into this, so we're going to pretend that this isn't up for a second. And really what I want to do here is to get everybody to participate in this. So I'd like to take a moment here to really step into the caregiver's shoes, because this is where we're talking about the caregiver's experience. And I'd like you to imagine yourself as the primary caregiver for a loved one with relapsed or refractory BALL who's about to receive CAR-T therapy. As we go through this, notice what thoughts and emotions come up for you. I'm a psychologist. I love to deal with emotions. And so I really want you guys to get into this. Okay, so you're a caregiver caring for a loved one who's about to get CAR-T. What's coming up for you? Just think about that. Take a moment. Now imagine the moment your loved one's doctor tells you CAR-T is the next step. They've been through multiple treatments, and now you're here. Take a breath and notice what your first thoughts are. Is it hope? Is it fear? Is it anxiety? What information would feel most important to know ahead of time? What would help you feel prepared? Take a moment to really feel into that. Now imagine packing your bag for the hospital stay, planning how you'll be there for every infusion, every check-in. How are you preparing yourself emotionally for this journey? All right. So I think this can be, we're going to pause there, hold your thoughts, hold your emotions, and I'm going to have you, we're going to continue that journey onward here. But before we do, I want to talk about like a caregiver guidance tool. This is really important, and I think that this can be a whole separate presentation for how to support the caregiver during the whole entire phase, right? So pre-treatment, treatment, and into survivorship afterward. So here we really want to explain to the caregiver, again, that's the educational piece, what to expect. So understanding what is happening. Again, neurotox is a temporary side effect of the treatment causing inflammation of the brain. This can lead to changes in thinking, in speech, behavior, and movement. These symptoms can be frightening, but are often treatable and reversible with proper medical care. Your loved one may feel confused. They may feel agitated or be different than usual, right? Personality changes here too. And so you really want to get the caregiver to understand that. And what we can also do here is to help them form questions to ask their medical team. How often do you see your doctor? You have all these questions on your mind and you're like, I'm going to ask this and that and this. And then you get there and all of a sudden you just don't remember what you were even going to talk about. And oftentimes visits are quick, right? It's not like you're spending an hour. And so especially the psychology team, but also others can help prepare them with questions to ask their team, right? I often like to tell caregivers and patients, what is your biggest fear? Now turn that into a question and ask your team. And that way you'll be better prepared, right? We can turn any fear or anything that's causing anxiety into a question. All right. I guess before we get to that slide, now back to our imaginal exposure here, where we're going to step back into the caregiver's shoes. Now imagine we're in the hospital room where your loved one is receiving CAR-T. You're sitting beside them. Notice the emotions that come up for you. Again, hope, worry, both, anything in between. What questions are swirling in your mind at this time? Think about what would help you feel included, informed, and useful in those first critical days. What support would matter most to you? All right, a few days later, things start to change. Your loved one becomes confused. Maybe they can't write a sentence, or maybe they don't recognize you. Perhaps they're agitated or saying things that really don't make sense. Notice what's coming up for you now. Now, if you could ask the medical team one question right now, what would it be? And if you can be given one tool, strategy, or piece of guidance to help you cope, what would it be? All right, now how caregivers can help in the moment. And of course, this isn't, an exhaustive list of things. There are a million other things that we could put into this. But at just the basic, staying calm and present, that's hard. Let's be real. Staying calm during a situation that's completely opposite of calm is really hard. When your loved one is sitting across from you and doesn't know who you are, the last thing you're going to do is stay calm. But as much as you can, we're going to try and stay calm. Your presence can be really reassuring. Speak slowly, clearly, use simple words and short sentences. Offer gentle reassurance. I'm with you, I'm here. Or the doctors are helping you. We also want to provide familiar comforts. So bring in familiar items, perhaps photos, their favorite music, maybe something from home that they really want with them, like a favorite blankets. I don't know. Keep the environment quiet and well lit, and try to maintain a consistent routine if possible. Now here, as with the medical team, you're also helping with orientation. So gently reminding your loved one where they are, the date, what's happening, using clocks or calendars or notes to aid in orientation, and avoid arguing or correcting if they're confused, instead redirecting calmly. 4 here is watch for signs of distress. So watch for increased agitation, restlessness, or withdrawal, difficulty communicating, or unusual behavior. Again, family members know their patients more than we do. So they're probably the first point of contact who's then coming to the team and saying, hey, this is weird, this is unusual. And so they're looking for that as well. Number 5 and number 6 are the most important in my eyes. Number 5, take care of yourself. Again, hard. Easy for me to say right now, right here. But in the moment, any family member is going to struggle with taking care of themselves. How often do you walk in a patient room and that person has been on that couch for the entire, 7, 10 days, sometimes months at a time, and haven't left, right? So as a caregiver, I would really encourage them to take breaks, eat well, rest when they can, leave the hospital. Again, easy for me to say, harder to do. And then seek support from our entire team. We have social workers, we have psychologists, we have other support groups. And so, we as the team offer that. And then in hopes of the caregiver taking something like that for themselves. And number 6 is us giving them permission to leave. So often, the family member is feeling a lot of guilt or shame if they leave. And so we have to be there to really give them that reassurance that it's okay to leave. You don't have to watch all of this. Your loved one is under great care. And I actually think that number 6 is the most important because this is all traumatic for the family member. Oftentimes patients don't really remember this. but the family member does. And so as Meredith was saying, the PTSD that might develop after this, our caregivers develop PTSD. Our caregivers develop these adjustment disorders with anxiety and depression. And so often the same sort of psychological issues and distress that our patients develop, our caregivers also develop. And so offering them that support. All right, we're getting back into our imagery that we were in earlier, but now it's more of this reflection. So take a moment now to reflect on this journey, from anticipation and hope, through uncertainty, to a sudden medical crisis. What stands out to you about a caregiver experience? What role do you think psychological support should play, not just for patients, but for caregivers and for providers as well? All right, we're out of the woods, right?
Yeah, right? Or are we? So what we really wanted to focus on today, in addition to that acute part, which is very important, is also some of these long-term motor neuron toxicities that we are finding, discovering, that are coming to our attention. I'm not quite sure what the appropriate terminology is. CAR T is pretty new, right? Like in the grand scheme of therapies, it's still new. And there were things even a few years ago that, IEC associated HLH was not a thing until we realized it was a thing. And then we said, oh, shoot, we should be managing this differently. We need some guidelines. In the same way, especially for our BCMA directed CAR T therapies, we're starting to see some of these prolonged motor neuron toxicities. I want to call your attention to the time of onset for these motor neuron toxicities. These patients are sometimes 50, 60, 70 days out, up to 914 days out for peripheral neuropathy. So that means we have done our job with their disease, but they are now dealing with the side effects of therapy, right? And this can be quite shocking for patients and, again, caregivers. Some of these resolve, some of these do not. You will also see the time to resolution can be quite a long time. So this is a marathon and not a sprint for these patients and their caregivers. We're going to focus today on the Parkinsonism. However, cranial nerve palsies can be an issue. Immune-mediated myelitis can be an issue. Guillain-Barré can be an issue. The Guillain-Barré was fatal for the patient that was reported in. But these can be quite devastating for patients. And I think tricky for us to balance, because in the same way that, we heard earlier from Julie about, the cardiac toxicity that doesn't show up until you're in your 60s, right? This is stuff that comes on later. And we can't necessarily say that you're in the clear or not, right? So how can we prevent these motor neuron toxicities? We can do enhanced bridging therapies, so we can make sure that they are really nicely tuned up, if you will, for CAR T therapy. And this early and aggressive management of CRS and ICANS. Remember how I was saying before, like we were all a little bit nervous about using steroids at first with our CAR T products, right? We actually know now that we should be much more aggressive than we thought we should have been, right? So as we move forward, you will see a lot more institutions who are using prophylactic medications or just treating grade 1 CRS very aggressively, whereas before we were like, it's probably fine. We can just treat them with a little bit of Toci, maybe. And now we're like, Toci for all. Let's just give it out like candy. And so focusing on this Parkinsonian syndrome, this you can imagine it from, textbooks way back in the day, right? It's our subacute hypokinetic movement disorder that emerges about 1 to 2 months, maybe, after our CAR T infusion, characterized by tremors, bradykinesia, limb rigidity, microphagia, shuffling gait, memory loss, diminished attention, reduced facial expression, or flat affect. Now I ask you, can you think of some other disorders that cancer patients perhaps go through that also look like memory loss, diminished attention, reduced facial expression, and or flat affect? This is tough. It's really tough to identify this one in patients. What do we think is happening here? Again, we're not quite sure, right? CAR-T is still pretty new. We think the pathophys of what's happening here is that there's a target antigen expression in the CNS that the CAR-T actually targets as well. Okay. And that is what is, the CAR-T is really good at its job, right? It hopefully cured your underlying cancer, right? But also it's targeting some of these other cells in the CNS. And so how do we see this? Again, time to onset is delayed. Time to resolution can be quite prolonged. We need to admit these patients for an expedited workup. As soon as you think that this is what's happening, we need to get them admitted because we know that if we can treat it earlier, we will have better prognosis for these patients. Some of those are our most common symptoms that we talked about before, and we absolutely must, we owe it to our patients to do a neuroconsult to make sure that there's not something else going on. Because, every time there's always the possibility that there's something else happening that we don't want to assume that it's simply the side effect. And so what are we trying to do in patients? There are, a few guidelines, quite a few new studies that are out where we're talking about giving prophylactic DEX. We're talking about especially monitoring these absolute lymphocyte counts and using that to direct our therapies a little bit for patients, as well as, again, sort of more liberal dosing of anakinra, which can also be prophylactic and or treatment, and tocilizumab. And so again, these are sort of what our symptoms and timing are going to look like with our CAR-T Parkinsonism versus depression, which, as you can imagine, is, not uncommon in our patient population, right? They look really similar. There can be some red herrings out there. So it's important that we all just be vigilant with our patients, right? And I think to Maria's point that she brought up several times, get to know them really well and listen to their caregivers when they say, this is different. This is not how they were before, right?
So there are marked facial features that are different between a person that, let's say, is a normal person versus one that has Parkinsonian disorder. And so you can see here that there's a diminished ability to show emotion. So patients may appear as flat, blank, or almost like mask-like. There's decreased blinking rate, so eyes may appear fixed or staring. Think somebody that's kind of staring straight ahead, not necessarily looking straight at you. There's a kind of this less spontaneous movement when it comes to smiling, frowning, or eyebrow movements. They're certainly reduced or absent. If you look at the mouth posture, the lips may be slightly parted, sometimes with drooling due to reduced swallowing frequency. Oftentimes there's voice changes that occur, and that actually can be noticeable to the patient. So I'll talk in a little bit here. I think it's in the next 2 slides or so, sort of what patients are able to notice and remember versus what they can't really, or what they have limited insight into. But voice changes is something that patients do notice typically. So often this is a soft, monotone, or low volume speech that adds to the impression of diminished expression that is there. And then if you look at the overall impression, it's kind of like this frozen face with minimal animation, even when discussing something emotional. So as you can see in the pictures here, the difference kind of is over here on the bottom too. And again, I also want to point out just how hard it is to know the difference between depression, especially as patients are going through a hard treatment. It's not uncommon for patients to endorse anxiety, depression, trauma symptoms. And so this has a lot of overlap with depression, even with the somatic symptoms too. Fatigue, that's in both. Poor appetite, that's in both. Oftentimes patients lack or have an inability essentially to experience joy. Perfect example here, right? And so it's really hard to tell the difference between depression and Parkinsonian. And so often the two overlap, but there are slight differences too. And the differences is really what you can see here and how they're presenting. Okay, just here's another image. But most importantly, we're going to get into the psychological interventions here. And I'm not going to go through each and every one of these, but I'm going to give you an outline of what might be helpful to really focus on. So Parkinsonian syndrome after CAR T is rare, but when it does occur, it's not just a neurological complication, it's a whole person crisis. Survivorship in this context requires not just living longer, but healing through the loss of what was and redefining meaning in what remains. And so this syndrome after CAR T, when we look at the psychological interventions, they're really multidimensional. We really want to normalize and validate, and you've heard me say this numerous times, but we really want to normalize and validate and acknowledge that the patient's suffering directly. So saying something like, it makes sense to feel overwhelmed. This wasn't the outcome anyone expected. Normalize grief, normalize anger, and normalize fear, as well as any other emotions that they or the caregivers might be coming in with. We also want to support identity reconstruction here. So using things like narrative or meaning-centered psychotherapy to help patients reconnect with who they are beyond their illness. Encourage small, achievable activities that reinforce agency and dignity. We can do this through different modalities like CBT, cognitive behavioral therapy. We can also use acceptance and commitment-based therapy, which is ACT. And what ACT focuses on is it's teaching distress tolerance, mindfulness, and values-based living. So really kind of looking at what's important to the patient, what's important to their loved ones, and how do we learn how to relate to our thoughts in different ways where we can still live a life that's worth living. And really what ACT does is it supports psychological flexibility. So living meaningfully, even when the future is uncertain. There's also family-centered counseling. So this is a type of counseling where we offer space for family members to express whatever emotional reactions they might be having too. I mean, in theory, they're mourning the loss of their loved one. And I'll go through that in the next couple slides as well. But we're also providing concrete strategies for caregivers to set boundaries for themselves and also for self-care. And then importantly, I think it's helpful to have palliative integration in this. And then occupational therapy can also be helpful for patients with mild cognitive impairment.
All right. So we now have another patient case. Miss M, she's a 51-year-old female with progressive multiple myeloma. She's gotten several lines of therapy. She received Carvykti, and 6 days after the infusion, she developed grade 2 cytokine release and resolved with tocilizumab on day +7. She became encephalopathic with disorientation and expressive aphasia. Her peak immune effector cell-associated neurotoxic ICANS score was 2. So her cognitive symptoms, though, resolved after about 4 days with dexamethasone treatment, and she was discharged home. 3 weeks after her CAR T infusion, she reported cognitive dysfunction, reduced verbal output, flat affect, shuffling gait. Central nervous system imaging was unremarkable with stable calvarial and skull bone lesions. Her neuro exam showed inattention, slowed responses, hypomimia, bradykinesia, cogwheel, and shuffling gait with reduced arm swing. What do we do to treat her with this Parkinsonian-like syndrome? This is tough. We don't really know yet. We've tried a lot of things, a whole lot of things, more steroids, more anakinra. We've tried dasatinib. We've tried siltuximab. We've tried classic levodopa. Seems like that should work, right? Works for Parkinson's patients who have not received CAR T. Unfortunately, it does not. This is really hard for, I think, us as providers, but also, again, for patients and caregivers to say, I'm sorry, wait, what? We're not sure what to do. One thing we do know is we can perform a lumbar puncture. So I just also encourage you to think about your multiple myeloma patients. While lumbar punctures are like, bread and butter for your ALL patient, this is not what these patients have gone through very often, right? So this is going to be hard and new and different. Oh, and by the way, when we do that lumbar puncture, we are also going to give you triple IT chemo. So we're just going to pop some chemotherapy in there. And that is also surprising for patients because, again, these myeloma patients in particular who are receiving these BCMA CARs have not necessarily gotten this kind of therapy before. So this is all new for them, right? It's like their first day at school. This is tough, right? So we're saying, okay, well, we again cured your myeloma, but now we have to deal with this whole other thing. And by the way, a whole new line of therapy that you're not used to. So this is again where our psychosocial team can be incredibly helpful as partners for patients who are dealing with this as their new reality. Worst case scenario, if we give a few more doses of triple IT chemo, we can say if there's really no improvement, we will give some IV cyclophosphamide. And why would that be a little sad for us? Because we know if there's one thing that's really actually going to deactivate that CAR T, it's going to be the IV cyclophosphamide. So now we have gone through this entire journey and you have been through the ringer 5 times over. We say, well, to fix this problem that we created, we're now going to give you something that's going to deactivate the therapy that was giving you all that hope, right? That maybe fixed your myeloma. Just again, imagine what this is like for patients and families having to make these decisions. These are impossible decisions for them to have to make.
Right. So early on, as I mentioned before, there are various symptoms that patients really have insight into. And so early on, patients can be aware of some of these features, specifically the motor and functional decline. They may notice slowed movement. They may notice that their handwriting is worse than it was before or changes to their voice. But because the syndrome often overlaps with neurocognitive changes, so things like memory issues, processing speed, attention deficits, patients tend to have limited or fluctuating insight as this progresses. So from a psychological standpoint, this complication is extraordinarily challenging, both for patients and their families. Imagine a patient survives a life-threatening illness through CAR T, only to then develop these debilitating neurologic symptoms that alter their identity, their communication, and independence. So this leads to a complex emotional cascade. So for the patient, again, it depends on how much they have insight into and how much recall they have. But certainly some may experience this grief and loss. Well, again, the loss of mobility, voice, autonomy, shame and isolation. They may feel like a burden to both themselves and their family members. Anxiety and depression and trauma, and so all the psychological issues that can develop after this. Cognitive distress. So, of course, this cognitive slowing can impair processing, memory, and insight, which further compounds stress. And then for the caregiver, I mean, this is really where we have to focus on the caregiver, because they're also experiencing shock and regret. So caregivers may question the choice of CAR T. I certainly would if I was a caregiver. Burnout, so the level of care that's now needed can be indefinite, which of course is exhausting, right? Life moves on despite what's happening in the room. So finances are a concern, right? Oftentimes caregivers need to return to work. If they have kids, so there's a lot of different roles that caregivers play, but especially if now they're dealing with something that is lifelong, that's going to completely alter the trajectory and the life that they were living. And then anticipatory grief, so mourning who the patient was before treatment. I mean, I think these caregivers are often experiencing grief at different time points. And there's, again, really no right or wrong way to grieve. But I think that the reality sinks in once, again, people return home and this is something that they're now living with permanently. And so oftentimes caregivers may ask about MAID, the medical aid in dying, and this could be considered, except this is really hard because to qualify for MAID, you have to have a terminal illness that has less than 6 months, that you have less than 6 months to live. And so if they now are in remission, they don't have a qualifying diagnosis. Now, again, I think, this could be a whole separate presentation, but there are some things that can actually qualify patients for MAID. So it's not completely off the table, but I think it's completely fair for caregivers to ask about this. So this kind of just stresses the importance that a multidisciplinary team here is really needed. That the caregiver partnership here is key, and that starts before treatment. So that starts on the initial visit that these patients and their caregivers have with the medical team. The medical team needs to be on board with what the psychology team is sharing, because if I just, educate my patients and their family members of what's to come, they're not going to believe me if the medical team is kind of downplaying some of these side effects that may occur. And quite frankly, I think that happens frequently, where again, we're trying to instill hope in patients and their loved ones of like, this is going to work. And so talking about the side effects and talking about how severe some of this can be is really important. Shock is going to happen no matter what, but they need to be aware of the outcome that this might lead to. All right, and so to summarize, the emergence of IEC therapies presents the opportunity for new treatment modalities for our patients and increased complications with those therapies. And then managing patient side effects relies on both clinical expertise and psychological considerations for patients and caregivers. And we have about 3 minutes. That was pretty good. For any questions, comments, concerns?
Thank you for letting us know. We'll make sure that they go up.
My slides also weren't up there, so.
Anybody else have any questions? That was Alex.
Okay. So yeah, I just had a quick question. I find it personally a little bit challenging, particularly in the outpatient setting when we're getting patients prepped for these therapies, how to adequately kind of describe and get them ready for what is kind of an abstract concept of neurologic toxicity and things like that. I was just wondering if you guys had any strategies to kind of get people prepared of what potentially could happen, because I feel like sometimes I'm like, all right, we asked these questions. You might have word finding difficulty, but it is all very abstract. So I was just wondering if you had any thoughts to that.
Going to start us off, and I'll go second.
I think, we actually, in getting ready for this talk, talked specifically about that to some of our attendings. And said, what are you doing in terms of consenting patients for these products now? And the response to us, which I actually was quite impressed by, to be honest with you, was like, yeah, CRS, neurotoxicity, we expect those now. Like, if you don't get those, okay, that's fine. But like, we spend way less time talking about those toxicities than we do these very rare side effects, because those very rare side effects, we don't want to be completely new as information as we're diagnosing them, right? We want them to have heard this at some point along the way, that this is a potential. And unfortunately, they are in that very, very small minority of patients who developed these toxicities, because it's too devastating otherwise to patients and families. And so that at least was the information that we gathered, was that like, it's really important that we actually focus a little bit more on those, even though they're scary, so that people know what they're getting into. You have a right and deserve to know from your medical team what the worst possible outcome is from some of these therapies. We also hope patients don't develop heart failure, but sometimes they do, and it's really important that we prepare patients adequately for that.
Yeah. And then, usually patients are seen by the doctors before they come to me. And so once they come to me, that's when I really assess for their understanding. Because again, oftentimes patients' family members are overwhelmed in these visits, and what goes in one ear comes out the other. And so I try to assess for, what is your understanding of this? What are your hopes? What are your worries? What has the doctor explained to you? What are the side effects? And so I'm really looking for like, what do they know? And if they're not naming some of these things, I'm then educating patients and their family members on what to expect. And then often, you can kind of read their body language. And so from there, you can, like, if people are getting kind of tense and not really listening, or kind of checking out, zoning out, whatever, is happening in that moment for them, I tend to slow down and then ask, like, are you somebody that likes a lot of information? What would be helpful for you? And sometimes I even ask that on the front end, but I do think it's important for patients to know this because even if they don't want to know, caregivers should know this, right? So if the patient then tells me like, I don't want to hear a lot of information, I just need enough to like get me through, I'll ask the caregiver, are you willing to hear what might happen? Because I think it's really important. And the caregivers usually really want all the information. It's usually patients that sort of check out of that. And that's usually a protective mechanism for them to get through what they're going through. And so, but I always start with the educational piece and then the understanding piece, because again, it's important for them to know. And that holds true for any treatment we do, for the stem cell transplants, for, I mean, really chemo, immunotherapy, for anything. So, and then there's follow-up questions that you can ask after that around, like, again, as you hear this, what's coming to mind for you, and all those things. So you can kind of do a deeper dive. I think the psychology team has a lot more time to assess their understanding, to walk through some of the possible side effects and et cetera.
Maybe a little bit more to that question. How often, so I guess in spite of all of the things that we do to prepare patients, whether it be the doctor or psychologist, or APPs, whoever, talking to patients about the major side effects of CAR T cell, how often do you think when it happens to them, they still feel like surprised about the situation? And I guess given that, because I've experienced that where they just seem really surprised about maybe the severity of the situation. Are there other ways that you guys use or that you can think of that could prepare these patients even better? Like, we can tell a patient that, oh yeah, neurotoxicity is this and this and this. But when it actually happens, there's so much more that goes into it besides just well, I've heard what this could be, but when they're actually seeing their loved one go through it, I know you talked a lot about it, but I'm just thinking, is there other things that we can do to even further prepare them for even those most severe situations?
That is a phenomenal question. And I don't know that I have a great response to it because I'm constantly trying to think of like, what can we do to further help patients and loved ones understand and or just help support them through this, right? Because I would say 100% of the time, patients or caregivers are really shocked when things like this happen. And I think that holds true to any treatments that we offer. When something bad happens, think transplant with GVHD, for example, they're like, I had no idea. And I'm sitting there being like, we talked about it, right? But obviously I'm not sharing that with them. Instead, I'm offering a lot more validation and reassurance there. But I'm not sure. And I think as like technology is becoming more developed, and there's different like apps and things that we can sort of give people. I think that maybe one day there will be an app developed of all of the kind of step by step so they can use that to then look back on. It's interesting though, because in the moment when it's happening, again, I said 100% of the time, I'd say 90 to 100% of the time, people are shocked and, are like, we've never heard this information before. But afterward, if you check back in, like give it some time, a month or two and check back in, because I always ask the question of like, did anything come as a shock once I meet with them on the other, side of treatment? Usually patients and their family members say no. The team did a really good job explaining everything to me. So I think it's this kind of acute grief response that happens in the moment and then it subsides as time goes on. And so the question of what can we do to better prepare these folks for this, I'm not sure. Because I do think that our team does a really good job educating on what to expect.
All right, everybody. I think that pretty much wraps it up. I think a couple of things I'd like to say is, thinking about the day today, and, we had six different groups of people today that are commonly involved with the patients we care for. And this is every single day. This whole all of these presentations, all of these topics, all of this collaboration, this multidisciplinary approach. This happens for our patients every single day. And this is actually only a portion of the care and the multidisciplinary collaboration that we have for our patients on a daily basis. And for me, that makes me pretty proud that we have a system and a place and a group of people like this and all kinds of specialty services that provide the very best care for patients every single day. So I think we should all be proud of that. And also, I think, I just want to thank all of our speakers who did just a wonderful job today, preparing, working so hard to put together slides and talks that were very informative. And I think that were just really great educational resources for everybody here today. And also, I want to thank all of our exhibitors, all the people that helped support this blood cancer boot camp today, all of our organizers today that have worked so hard for months to put this together, and everybody here that came today to, I think, take part in this day of presentation. So anyway, thank you very much. I hope everybody, we've got Rachel who put in so much work. We got Dan back there. We have a whole crew of organizers that, like I said, have worked on this for so long, but certainly Rachel is at the helm of putting this all together and really appreciate that. So anyway, we look forward to next year's blood cancer boot camp, and really appreciate everybody coming, and thank you very much.